Yeah. Okay. So we're going to be talking about just like intro to OCD and like exposure response prevention. So just like supporting clients with OCD and then also to any other like anxiety disorders through exposure therapy. So I'll just do like a brief kind of intro going over what OCD like actually is, and then really getting into like the nitty-gritty of exposure therapy. So hopefully this will help you understand just like OCD, how you can implement ERP in practice, and then just some like practical tools and exercises that hopefully like you guys can use for your clients if they're struggling with OCD or if they're struggling with like anxiety or panic or a phobia or perfectionism, even all those great things. So again, hopefully by the end of this, you'll be able to recognize just some common OCD presentations, understanding assessment for OCD, which is the Y-BOCS, which we'll get into, ERP basics, how to build like a hierarchy with your clients and doing some exposures, and then just like exploring how to actually apply ERP beyond OCD as well. So just a quick overview of what is obsessive compulsive disorder. Kind of what it sounds like, obsessive and compulsive. So you're going to have, or your client will have, intrusive thoughts, images, urges. Those are going to go under the obsession category. Most of my clients, from what I've seen, struggle with more of the thoughts and the urges. I do have some clients that will have violent images or just, reoccurring images. But again, anything that is going to be obsessive. So any intrusive thoughts that are causing them distress, they don't want to be thinking about it. They don't want to be having this urge. They don't want to be having this image, but it just feels like they can't let it go. I always describe it as like, you almost have like a thought that passes by, but it's like a sticky note and it just gets pinned. And it's like, oh my gosh, it's here. And that's all I'm looking at. Can't let it go. Then we have the compulsive piece as well. So compulsions are going to be behaviors or mental acts in order to reduce the distress that the client feels. So of course, these intrusive thoughts will cause anxiety, will cause distress, will cause some sort of just uncomfortable feeling where the client will believe, oh my gosh, the only way to get rid of this is to do some sort of compulsive behavior. So the OCD cycle, we have a trigger, we have then the obsession, the anxiety that the person will feel, then they engage in the compulsive behavior, which I will always say it does provide temporary relief. That is true, because sometimes my clients will be like, well, how come I feel better after it? Yeah, it's relief, but it's temporary. And then what you are doing by that is reinforcing that cycle. So you will create more fear to that intrusive thought, or more of an urge, or more fear to that image that you are having. And then it feels like, oh my gosh, I have to do the compulsive behavior. And that will grow over time. The core issue too of OCD, which is just important to keep in mind for any like subtype of OCD, is it's the intolerance of uncertainty. So a lot of times obsessions will be like, how do I know this? Or how can I be certain? Or what if this? And it's like no amount of certainty will ever be enough, it feels like. And that's just because we can't ever have 100% certainty with anything in life. So again, the really core issue of this is just the intolerance that a client will have to uncertainty, because of course that feels uncomfortable. But we have to teach them how to be okay with this. So kind of the cycle of OCD right there. And then there are some just like common OCD subtypes. I tried to pick a few of the ones that I see the most with clients. So contamination OCD, that is where clients will be really, concerned with like germs, diseases, any sort of contamination. So any obsessive thoughts with getting sick, contracting some sort of disease, something being contaminated, things like that, harm OCD. So here is where a client is either concerned with like harm to themselves or harm to another person. So a lot of intrusive thoughts of, what if I accidentally hit someone? What if I like push someone off of this ledge? What if I accidentally hurt myself? What if I cause harm to another person or to me? Existential OCD, this is kind of where we have thoughts about just like the greater kind of unknown. So sometimes clients will have a lot of recurring thoughts of like, well, what's the purpose? What is my purpose? How do I know? What is the point of life? Kind of getting stuck on those recurring thoughts. Just right OCD. So this is that feeling. This is more of like those urges that a lot of clients will have of like, I just have to do something and it has to feel just right. Like for example, right now I'm working with a client who they will have a lot of urges to constantly walk through in and out of their door like multiple times until it feels like just right. And there's no number to this. There's no, reason behind it. It's just a feeling of like, okay, this feels right. This feels good. Now I can continue on with my day. Mortality OCD. So a lot of obsessions around, am I a good person? Am I a bad person? Am I morally correct? Am I doing anything that might offend somebody? Did I offend somebody? How do I know if I offended somebody? Am I maybe secretly a racist? Things like that. Pedophilia OCD. This is a common one that will cause a lot of shame in clients. So this one can sometimes be, I don't want to say like ones that clients will wait a while to share, but I've seen clients kind of share this like later on in the therapy journey. But again, a lot of intrusive thoughts of like, what if I want to like harm my niece or nephew? Or what if I'm secretly attracted to my child or a niece or nephew or a child, things like that. I know there's more, but that was a lot to throw at you. So any questions with any of these subtypes of OCD? No. Okay. Postpartum OCD, you know what that is. Paige went over that the last time so wonderfully, so I'll skip over that one. Pure OCD, this is what we kind of call like purely obsessional. So this one we won't see clients really have a lot of behavioral compulsions. These will be more of those mental compulsive behaviors. So they will have a thought and they will just obsess about that thought. They'll ruminate on that thought. It just feels like they're constantly going and going and going. You might not even know that they're engaging in a compulsive behavior. So this one can be sneaky. Relationship OCD, big, big, big one. So a lot of obsessive thoughts of like, how do I know this is the one? How do I know there's not someone better out there for me? How do I know if this relationship is going to last forever? I'm having an urge to break up with my partner, but I don't really want to break up with them. Why am I having this urge? Things like that. Religious OCD. So this one can be super common. I see this a lot of times with clients who kind of grow up in like a very religious background, but sometimes just having thoughts of like, what if I just sinned? Am I sinning? What if I go to hell? How do I know if I'm going to go to hell? Praying excessively, to whatever their God that they believe in. Responsibility OCD, having this like obsessiveness around responsibility and what they're actually responsible for. So, if I forget to lock the door and someone, comes in and robs our house, like it's my fault. It's my fault that our house was robbed. It's my fault that the house was, ransacked. It's my fault that I didn't check the oven and the oven might have accidentally been left on, and it would be my fault if the house burnt down. So a lot of responsibility there. And then sexual orientation OCD. So what if I'm gay and I don't know? What if I'm actually attracted to the same sex and I don't know? What if I'm attracted to the opposite sex and I don't know? How do I know for sure? Obsessions with that. So I think just a reminder for clinicians is that OCD themes can kind of feel like infinite. They can kind of feel like, oh my gosh, there's just so many of them. And so as a clinician, just trying to not get like stuck in the theme, really knowing that like, okay, it all still follows that same cycle. The compulsive process is still the same, regardless of the obsession and regardless of the compulsive behavior. It is still following that outline. So just trying not to get caught up too much in like the context of it and really grounding ourselves in like, okay, see the obsession, see the act of the compulsive behavior, and I see like that reinforcement there. So just some like common clinical questions that I have gotten before, just from other like therapists, but even from clients. Is this OCD or anxiety? What if the thought is actually true? Should I reassure my client in a session? And then like, are intrusive thoughts dangerous? So just like an overall reminder, intrusive thoughts are normal. Even people who don't struggle with OCD will still experience an intrusive thought or maybe like an intrusive image or sometimes an urge to do something. That doesn't automatically mean the person has OCD. So just knowing intrusive thoughts are normal, but then in OCD, there is that distress and then obviously that compulsive behavior. That's where the problem lies, is that we are doing a compulsive behavior to try to neutralize or get rid of the anxiety and the distress that we feel. So again, intrusive thoughts, not really the problem. Problem lies in how we are responding to it. And then knowing too in session, it can be hard to not reassure a client. Sometimes too, I can even find myself like getting caught up sometimes in their obsessions where I'm like, I could just like reassure that maybe it'll go away, and it won't. And so knowing that like for us, like reassurance is a compulsive behavior. They're looking for that. And so we're really trying as therapists to just focus on like tolerating the uncertainty with them. So if you have a client who struggles with contamination OCD and they're like, well, how can you be sure that this doorknob isn't contaminated? You've been able to say, I don't know. Maybe it is, maybe it's not. I don't know either. Right. So really having to do that, which can sometimes feel cruel or can sometimes feel like you're not helping the client, but you are, and their OCD is just talking to you in that moment, really wanting that reassurance there. And then just a quick overview, like from the DSM, like exactly what OCD is according to the DSM-5. So you have obsessions that have to be defined by both 1 and 2 here. So they are reoccurrent and persistent. So that's like the obsessive nature of them. So the client is constantly kind of having these thoughts. They're happening more than just once. Again, it's not that just like one intrusive thought that maybe someone had and it was just like, whoa, that was kind of out there. These are reoccurrent and persistent thoughts, impulses, or images that are experienced at some time, and they are disturbing and intrusive and sometimes even inappropriate, and they can cause anxiety and distress. And then, of course, the individual can also attempt to ignore or suppress these thoughts, urges, or images, or to neutralize them with some other like thought or action. So performing a compulsive behavior. And then compulsive behaviors, those are repetitive behaviors. So like hand washing, ordering, checking, or those mental acts. So praying, counting, maybe repeating words silently, ruminating, that the person feels driven to perform. So again, that's kind of that keyword there where it feels like they have to do this. This is a strong urge. They don't necessarily want to be doing it, but it's like, I feel this drive to go and do this. And it's a response to their obsession or according to like a set of rules that they have for themselves that must be applied rigidly. That's that keyword too. Compulsions are very rigid. They're very like urgent. I have to do it right now and I have to do it in a certain way and it has to look like this. And again, the behavior or mental act, really just the goal of it is trying to prevent or reduce the distress or prevent some dreaded event or situation. But again, these compulsive behaviors, they are not connected in a realistic way with what they're designed to neutralize or prevent, or they're clearly excessive. Some clients will realize that their compulsive behaviors are excessive. Some clients won't. Some clients will feel like that is, quote unquote, normal, or it is just something that they have to do. So just being able to, in a kind and soft way, really give that kind of definition to a client that, okay, compulsive behaviors are clearly excessive in their nature. And then again, the obsessions or compulsions are or cause marked distress, and they are time consuming. So they might take more than 1 hour a day, or they significantly interfere with a person's routine, academics, school, functioning, relationships, all of that kind of stuff. And then I won't go over all of this, but this just also explains like that in order for it to be OCD, it can't be better explained by the symptoms of all of these different types of mental disorders. So again, this is why sometimes like OCD can be so hard to spot, because it can feel like anxiety. It can feel like, wait a second, is this like skin picking? Is this hoarding? Is this, all of these different kind of disorders. So all of that there I won't go over, but just to know it has to be kind of ruled out. And then of course too, it can't be because of any sort of physiological effects of a substance either. Okay, before I go over this, any questions with like what OCD is or like the DSM? Okay. I just wanted to throw this in there because I feel like this is a big one. Sometimes I still even get like tripped up on this with like some clients. Really knowing the difference between generalized anxiety disorder and then OCD. I think the tricky part is that with OCD, the client will feel anxious. So sometimes a lot of clients, especially if they're unfamiliar with OCD, they might come in describing things as like my anxiety, my anxiety, my anxiety. And then you kind of maybe look at their, GAD score, and it's like, well, you scored like mild or subclinical. So, what might really be kind of going on here? But just some key differences. So generalized anxiety disorder, the worries are generally like plausible everyday issues. Like, what if I lose my job? What if my child gets hurt? What if I get sick and I have to be out for a while? What if I don't make it to the next paycheck? Very just, plausible issues. And the worry here can feel like an attempt at like problem solving or preparation. There can be that spiral, which might look like rumination. But the worry, it feels like an attempt to solve something or prepare for something because the client's so worried about like, what if this thing happens. Compulsions are typically not present. So yes, people with anxiety will engage in like maybe seeking reassurance, maybe over preparing. But the key here, they are not as rigid, they're not as ritualized, and they're also not as like bizarre as you see in like OCD, where we're like, wait, that compulsive behavior does not align with the thing that you're obsessing over. And then again, with generalized anxiety, it's general. So it's very broad, and we've got like those kind of different worries, and they're shifting across many domains. OCD, obviously we kind of went over what it is, but again, it is the irrational, excessive, or disconnected from like a realistic probability. They can attach to everyday concerns like relationships or like, responsibility, things like that. But again, the obsessions are often like very excessive. They're spending a lot of time thinking about it. And then of course there is that compulsive behavior as well. And then knowing that OCD is ego dystonic. So the intrusive thoughts or images that a person's experiencing, it's inconsistent with those person's values. So they don't want to be thinking about this. They don't want to be having that urge. They don't want to be having that image or that thought. But it feels like, oh my gosh, I have to worry about this thing. I can't let it go. That Post-it note is stuck in my brain. And now I have to do this compulsive behavior. And then again, even when the obsessions are about like realistic life concerns, again, that reaction is going to be disproportionate, and there is going to be that like ritualized compulsive behavior that is just constantly driving that cycle. So just quick example of it, generalized anxiety, worry. What if my child gets hurt at school, right? So, okay, I feel like I should plan ahead. Maybe I can get him some safety gear. Maybe I'll call the teacher, let the teacher know what to do just in case my child gets hurt. So again, kind of feels like that problem solving. versus a responsibility OCD obsession. What if my child gets hurt because I didn't check their backpack 3 times? Oh my gosh, well then this is going to be my fault. Now it feels like I'm trying to like prevent this like catastrophe, and it can also trigger compulsive behaviors. So now I'm checking their backpack 3 times ritualistically. I'm doing this every time before they leave for school. Or having this thought of like, I need, right? I have this urge, I need to go and check my child's backpack or else they will get hurt and it's my fault, right? So that could just be the thought that pops into their head. Okay. And then the Y-BOCS. So this is an assessment that is used for OCD. I will typically use this with clients if they're coming in and they're saying they think that they might have OCD, or maybe a past therapist has told them they might be struggling with OCD, or if they are, again, throwing out that word, really anxious. I have a lot of anxious thoughts. I'm spiraling. I can't stop thinking about this, but their GAD score is not really reflective of that. Like they might have a really low GAD score. That's when I'm like, all right, let's throw the Y-BOCS your way. So in the Y-BOCS assessment, there is a symptom checklist. So they have symptoms of obsessions and compulsive behaviors. And then it also measures the severity. So the time spent on those, the distress level, the impairment as well. And you can use it for a baseline of tracking progress. And I have, let me see if I can share. Yeah, I can share this tab instead. So this here is actually the Y-BOCS like assessment. So again, really like listing it out, questions 1 through 5 are about the obsessive thoughts. So it will ask the client how much time is occupied by your obsessions, interference due to your obsessions, distress associated with it, resistance against obsessions, and then degree of control over your obsessive thoughts. And then the next couple of questions are spent asking about compulsive behaviors. So same kind of thing, time spent, but now time spent on compulsive behaviors, interference because of compulsive behaviors, distress associated with them, resistance associated with compulsive behaviors, and then degree of control over your compulsive behaviors. And then the Y-BOCS, let me go back to sharing. It's here. So the Y-BOCS is scored out of 31 possible points. So there is subclinical, which is a score of like 0 to 7, 8 to 15 is mild, 16 to 23 is moderate, and then 24 to 31 is that severe range. So this can actually just be a good way to measure clients' progress, especially when starting exposure therapy. You might see that they have a high score before starting exposures. And then over time, hopefully we want to see that score go down with exposures, which we'll get into why. But this is a really good assessment to use with clients, and it's one that you can just do again and again and again with them. And I just added like a quick little note here. Psych surveys, I can't remember the exact name of what it is called, but they have like a version of the Y-BOCS where it assesses for different common OCD themes. So all of the questions are kind of split up into like harm OCD, compulsive OCD, sexual orientation OCD, responsibility OCD, etc. And it will ask clients like, do you ever experience thoughts about harming yourself or somebody else, and a bunch of other questions. And from that, you'll kind of get an idea of like, okay, what type of OCD is this client struggling with? So they might have like no contamination OCD whatsoever, but they might have a lot of, let's say, relationship OCD. That's where a lot of their obsessions lie. So I've used this before with clients who maybe are like new to OCD, don't really know like what their OCD themes are. This is a good one to use with them. Any questions on the Y-BOCS? Okay, so now getting into the good stuff. So ERP. So this is the gold standard for OCD. This is what I use with all my clients for OCD. What it stands for is exposure response prevention. So exposure, obviously we confront that feared thought, that feared image, that feared sense or situation, or even to really confronting like the urge as well. But then there's that response prevention. So the response is we need to do the exact opposite of what your OCD wants you to do. So we're resisting that ritual, we're resisting that urge, we're resisting that compulsive behavior. And the whole point of this, what we're really trying to learn, is that anxiety doesn't have to be reduced to be tolerated. So, like, you're always going to feel anxious. Anxiety is always going to be there. But we really want to learn, like, okay, we don't need to have this like go away. We don't need to have this like disappear in order for you to be able to tolerate it. And actually, if you learn how to tolerate your anxiety and you learn how to tolerate that discomfort, you will feel a reduction in it. Like it will be reduced. So that's just an idea that clients have to like kind of come around to because they're just so used to that like really rigid ritual compulsive behavior urge that they've given into. And why it's so hard for them to come around to this idea is because, again, that temporary relief that they have found. Because it is true, their compulsive behavior is providing them relief. They just have to recognize that it's not long term and it's actually giving into that kind of just like repetitive nature there. So how this works, two different ways. One is habituation. So habituation is just that decrease in response to a repeated trigger. So a decrease in your anxiety to that repeated trigger. So again, the mind and the body become accustomed to the trigger, and then that client will no longer have like such a strong kind of like anxiety response to that trigger. So someone with contamination OCD, they're going to repeatedly touch an object that they believe to be contaminated, and they're going to find that through this repeated exposure, they are going to notice a decrease in their anxiety. So let's say doorknob is something that is a trigger for them. Through repeated exposure of this doorknob, they will start to have their anxiety decrease, and then eventually they will habituate essentially to that doorknob. But also there is something called inhibitory learning, which this is where we focus on learning new and safer associations to replace old or fear-based ones. So I tagged a little excerpt here from the International OCD Foundation where they're going to go into this a little bit more and talk about inhibitory learning and what it really is. But they have found that in order for ERP to like optimally be the most effective that it can, clients also need to learn safety in a way that can kind of inhibit that original fear. So what we want to do with this is really kind of exposing that client to, again, that feared situation, but also creating new knowledge that like, hey, this doorknob, like it's safe, and this outcome that we are thinking of, the outcome of contracting some sort of disease, it's very unlikely to occur because, hey, you've touched this doorknob over 70 times with me in sessions and you haven't gotten sick from the doorknob. And even if you have gotten sick, maybe it was from the doorknob, maybe it wasn't from the doorknob, maybe it was from your child, maybe it was from a friend, maybe it was from something else. We don't know. So again, another example of this is when clients struggle maybe with like panic, and this is getting a little bit out of OCD, but you can do exposures with panic where a client can learn to function and tolerate panic symptoms when they're in a feared situation and know that, again, like their anxiety will naturally kind of fall. So now they're no longer associating, let's say, working out as like a bad thing or a feared situation when they feel those panic symptoms arrive. And then here's just a cute little image I found online. It's a little blurry, but I will explain it here. This just kind of explains what exposure therapy is. So when you feel anxiety or when we're in a situation that is causing some sort of distress, so obsessive thought, image, all of that, we imagine that anxiety will increase like that image with the black circle. That is how clients usually think it will go, right? Like, oh my gosh, if you expose me to something that's going to increase my anxiety, I'm going to lose control. I'm going to die. I'm going to get sick. This thing is going to happen. That is how we imagine it. However, how it really works is that the more we expose ourselves to anxiety, over time, the anxiety will not get as high. So you can see that through like the blue curves right there. When a client first does it, their anxiety does kind of go up, but over time it will fall. And also, we're seeing that it's not getting as high, their anxiety, and it's also taking less time for their anxiety to come down. So, ERP really teaches the client to like ride out that curve, ride out that wave. We are going to learn that, hey, this will weaken over time. Your anxiety will weaken over time through repeated exposure. Okay. Any questions on like exposure therapy or what it is, how to do it? We'll kind of get more into how to do it later on, but any questions up front? Now, you, in order to do exposure therapy, need hierarchy because we have to understand, okay, well, what is going to be the thing that like we are even doing exposures with? So I kind of did it a little bit differently here. I tried to add in like different themes of OCD, but normally a client, let's say if they have contamination OCD, all of their triggers will be like a doorknob, kitchen countertop, grocery stores, public transportation. It'll kind of be all in that same theme. But so this first step is you've got to list the trigger. So what is that thing that triggers that obsessive thought, that image, that urge? So triggers can be people, especially for when you struggle with relationship OCD. So it might be your partner. It can also be places. So for contamination OCD, public transportation. It can also just simply be thoughts. So you might just be walking to work one day and you have a random intrusive thought that kind of enters your mind. Again, it can also be images and situations. So here, let's say a couple different triggers that I've seen before. Touching doorknobs, that can be a trigger. Driving can be a trigger for people. And then also just an obsessive thought or an intrusive thought. Hit this person with your car. That can also be a trigger. Then listing out the obsession. So I've done this a few ways with clients where before I've just kind of listed out the trigger and then the anxiety or the obsession and the anxiety, but sometimes clients will get confused of how it differs from just like general anxiety. So I've kind of found that breaking it down, like, okay, there's a trigger, there's an obsession, there's a compulsive behavior, there's anxiety, just helps them kind of grasp it a little bit easier. So with the touching doorknobs, that client, their obsession might be, well, I'm going to get sick. I will catch a disease. What if I contract HIV from touching this doorknob? What if I die because of that disease? So again, they're clearly concerned with contamination, OCD. Someone who has a trigger of driving, maybe every time they get in the car, they have a thought of, well, what if I hit someone and I didn't know it? What if I accidentally just ran over that person? What if that bump was actually a person lying in the road and not a bump in the road? And then some person might just have a random intrusive thought of like, hit this person with your car. So maybe like driving, yes, might be a trigger for them. But for them, it might also be like, well, sometimes I'm driving and I don't have this intrusive thought. It just happens randomly. And then they might obsess of like, well, do I actually want to do that? If I have this thought, like, do I really want to hit this person with my car? So listing out all of these obsessions and then listing out the compulsive behavior. So what is the thing that the client is doing because of that obsession and because of the anxiety that they feel? So someone with contamination OCD, they might avoid touching that doorknob with their hands. So they might have somebody else grab it. They might use a tissue paper to kind of grab it. They might use the sleeve of their shirt to grab it. And then maybe even they wash their hands excessively after they touch the doorknob. So maybe they touch the doorknob and then they have to go and wash their hands 3 times or for 5 minutes or however long. For the driving, if someone has that obsession of like, what if I hit someone and I don't know, we might see that they are compulsively checking their mirrors. So they're constantly looking in their rear view mirror to make sure they didn't hit someone, there's no one lying in the road, they didn't accidentally do something that they don't remember. They might seek reassurance. Maybe they're driving with someone next to them and they might say, like, was that a person? Did you see that? Did I accidentally hit someone? Did I hit that person that was on the sidewalk and not know, et cetera, et cetera. And then if someone has, again, just a trigger of like hitting this person with your car, like go and hit this person, they might check their feelings. Like, oh my gosh, do I actually want to do that? Well, let me see. Let me see how I feel if I like repeat, if I ruminate on that thought. Or, oh my gosh, well, I don't know if I actually want to do that. So let me just take precaution. Let me not drive near sidewalks. I don't want to drive near a person. If I see a person, I might go to the opposite side of the road just so I don't hit them because I'm having this thought to hit them. And then you want to rate the level of anxiety that they feel. Normally, you can rate this from 0 to 100. I have found that a lot of my clients, that actually causes them anxiety to do, and it can sometimes take a long time to get through the hierarchy to give them that big of a jump. So I just give it 0 to 10. Like 10 being the highest level of anxiety you feel, 0, you're feeling nothing, and I don't know why it's on here then. So having them rate it, and then normally it wouldn't be rated like this, but sometimes, you might find it's like 5 and then a 3 and then a 7 and then a 10 and then a 1. If it were like that, you would just want to re-rank it in order of severity. So starting with the lowest level anxiety that the client feels, and then having the hierarchy go all the way down to the highest level of anxiety that they feel. And then you would use this to start your exposures. So you would start with the lowest level of anxiety, and then you would work your way up to the highest level of anxiety with them. We don't want to jump into the highest level because we are going to terrify them. Sometimes you will have clients. I have a client where they're just a go-getter and they want to do the highest level first and just knock it out. No, remind them that this is actually going to have like a negative effect on them. So just some exposure ideas. So let's say, again, you have a client who struggles with contamination OCD. Maybe their trigger is touching doorknobs. The obsession is, well, if I touch this, I will get sick with the disease. Compulsive behavior, I'm going to avoid touching this with my hands. I will excessively wash my hands after I touch. So there's 2 different types of exposures, imaginal and then in vivo, which is just like in real life kind of exposures. I usually start with the imaginal ones. They tend to be a little bit easier for clients and really to do in session, especially if you can't do one that is like outside of session, like driving or something like that. So you would have this client maybe write out the thought. Okay, let's expose you to that thought and not go and wash your hands, or not seek reassurance, or not Google if that's actually possible. We're just going to write down I'm going to touch this doorknob and get sick with the disease. Okay. So what the client is learning with this is that it's just a thought. That is it. They're exposing themselves to this thought and learning that we don't have to analyze it. We don't have to figure it out. It is simply just a thought. Then we would take it up a little bit. So then maybe having that client now say that thought out loud. Then we could also do something like a worst case scenario. So it's like, okay, let's write a worst case scenario of what would happen if you did touch this doorknob and you did get sick with the disease. Write it out. Expose yourself to the worst case scenario here. And then in real life exposures, you would maybe have the client just stand near a doorknob. And then you might have that client go and touch a doorknob and delay their urge. So, okay, we're going to have you touch this doorknob. I want you to sit with that urge to wash your hands for 30 seconds, a minute. And then, okay, if you still want to go wash your hands, you can. Then we're going to work our way up to touching the doorknob and completely removing the urge. So if you've worked your way up to delaying the urge enough, you're going to get to the point where you removed it. And then maybe you have the client hold the doorknob. So, okay, we're going to have you put your hand on the doorknob, hold it there for a minute, and then delay the urge to go wash your hands, et cetera, et cetera. So you keep kind of building upon this. I will say it depends on the client. So You are going to have some clients where like standing near the doorknob, that's not really going to do anything for them. They're not going to feel any anxiety. And then you might have a client where it's like, that is enough to like really elicit a lot of anxiety in them. So it's also kind of just tailoring the exposures to the client, to the individual, and kind of like where they're at with their OCD. And then just a reminder again for us and for the client that OCD wants 100% certainty. So this client wants 100% certainty of they will not get sick if they touch this doorknob. Like that is what they want to know, or they want to know like that with 100% certainty, there is no germ, no contamination, no nothing on this doorknob. However, none of us can ever have that kind of certainty about our thoughts, about our feelings, about those images, etc. And the more that we try to figure it out, or the client tries to figure it out, the more that we get stuck. So I always like to remind clients, like, our work is not about proving whether it's true or not. So like through exposures, we're really not trying to prove if it's true or not. It might come with time of like, again, after touching it 70 times, they realize they haven't gotten sick. But it's just about changing how we respond to that doubt. So when you have that doubt of, if I touch this, will I get sick of the disease? It's maybe you will, maybe you won't. We don't know, but it's just a thought, and we can still touch that doorknob with that thought that we were having. So learning to tolerate that uncertainty is really our goal here. And then just troubleshooting if exposures ever go like a little awry, which it's normal if they do with clients. If a client avoids, so if a client's like, I can't do that, there's no way I would be able to do that, I don't want to do that, or you're finding that maybe they're not doing like exposures for homework, start smaller. So readjust the exposure then. So, okay, maybe we're not going to have you touch the doorknob just yet. Maybe we're just going to have you stand next to it. Would you be willing to do that? Again, normally clients with OCD are very motivated. They really do want to do these exposures. So if they are avoiding, it probably just is a sign that we got to kind of start smaller, and also reinforcing the wins too. So if all the client did in session that day was stand next to the doorknob and they inched closer, great. We're going to celebrate that. That's amazing, because maybe before they weren't even able to like walk past a doorknob. If a client says that this feels scary, harmful, or like cruel, wanting to just kind of reframe that for them of like, we're actually learning to live freely. So we're learning to live in alignment with your values, what you want to do with your life, being able to drive, or being able to open the door and not wash your hands excessively, or have to spend all your time in the bathroom washing your hands while you're at like a public place or whatever. We are learning to live freely. We're not learning to get rid of these thoughts. We can't do that, but we're kind of changing the way that we respond to them. So it can feel scary, but that doesn't mean that it's actually harmful or cruel or wrong of us to do. A big one is clients will say to me, like, what if this actually isn't my OCD? What if the doorknob is actually contaminated? What if, OCD is lying to the both of us right now? Reinforcing that like OCD will often show up in this way. So you questioning like, is this my OCD? Actually probably is the client's OCD. So just letting them know that OCD will often show up by making you doubt whether something is OCD, or whether it's something that like you need to figure out in real life. And then also too, for us, just knowing that there are like sneaky compulsive behaviors as well. So again, like those like little moments of reassurance, or if a client kind of seems distracted, but they're like, no, I'm not washing my hands. It's like, well, maybe they're counting now. So kind of just like us being able to look out for like those mental compulsive behaviors, and being comfortable enough to ask our client if they're doing any of those, even though it looks like they're not doing their typical compulsive behavior. And then to avoid clients backing out, I always say set expectations up front. So this is what you guys are doing. This is what exposure therapy is. Provide the psychoeducation, lots of psychoeducation, education on OCD, all of that, so they know exactly what it is that they are getting into, that can help them. kind of feel like, okay, I know what I'm doing here. I know the process. It's nothing that like I'm going to be unaware of. And then really quick, I know we're almost out of time, so I will just wrap this up. How to use exposures beyond OCD. You can use this with anxiety, panic, health anxiety, social anxiety, perfectionism. Again, it's kind of just taking what the client is like currently doing for their anxiety or their panic and just learning how to respond to it differently. So, social anxiety, all right, maybe you typically put your head down, ignore people, don't say hi, don't make eye contact. We're going to work our way up to kind of doing that. Or if you have a client that struggles with perfectionism, okay, I want you to purposely send an email with a mistake and sit with that discomfort. Again, it's learning to sit with the discomfort and tolerate the uncertainty of like what's going to happen, what that says about them, what that means, et cetera, et cetera. So just like a quick little sample here, beyond OCD for social anxiety, this could be like a hierarchy. So maybe a trigger, making eye contact with strangers, talking to strangers, going out to dinner with just friends that are casual. So again, exposing them to that feared social situation. We're wanting to resist any of like their safety behaviors. So for social anxiety, that's a lot of like avoiding eye contact, maybe over rehearsing what you're going to say, just having your phone out whenever you're like walking or with strangers. And then the goal is to learn that the feared outcomes are usually less catastrophic than maybe our anxiety is anticipating. And we also want to learn how to tolerate that anxiety. So an imaginal, all right, right out of worst case scenario, again, of like talking to a stranger and it goes terribly. Maybe you role play like a conversation with a therapist. So in session, pretending like you're a stranger and what would the client say to you? I've also done like, if I was like a Starbucks barista and having the client make small talk with me in like session. And then in vivo, smile to someone. So maybe that's an exposure that they do. And then saying hi to a stranger and then asking a friend to dinner first and not waiting for them to ask you. And then really just like key takeaways, OCD is not just being neat. A lot of clients will come in because of Instagram or TikTok and say they think they have OCD and it's not. So just knowing for us, it is those obsessive and compulsive behaviors, intrusive thoughts. It has to be distressing. Compulsive behaviors are done to reduce some sort of like dreaded outcome. Content can be about anything. Again, we don't want to really get caught up in the content, knowing that the doubt, the distress, the compulsive behavior, it is the same. Reminding clients that they're ego dystonic. So even if they're having thoughts about, hit someone with your car, this is not in alignment with a person's values. That is why a lot of times it will cause shame and confusion. So we just want to provide that psychoeducation. Looking for mental rituals for us. So again, not all compulsive behaviors are visual. You will have clients that will count, will say things, will do praying, reviewing, anything like that. Not providing reassurance in session. And then also don't confuse values with like OCD themes. So just because someone like obsesses about relationships or safety doesn't mean that they actually have like real issues in those areas. So if a client is obsessing about like, should I break up with my partner? Should I leave them? Should I this? Should I that? Doesn't actually mean that there's like a real issue in their relationship and they need to. Again, the essence is just to tolerate uncertainty and also to learn how to remove those compulsive behaviors by learning how to tolerate anxiety as well. So the uncertainty of the thoughts and then tolerating the anxiety and the discomfort that we feel in our body. No, that was a lot. Any quick questions, thoughts, confusions, anything that I can answer?
First, thank you. This was so thorough and you made it so digestible as well. So I just wanted to add that I think what's important is when working with folks with OCD, or even like you said, like even if it's not OCD, like creating hierarchies for perfectionism, hierarchies can be really beneficial even for like people pleasing. And okay, if you have a difficult time saying no, why don't we create a hierarchy of all the things you have a hard time saying no to,
Yes.
And then systematically one by one go through it.
Yeah.
I think just stressing the importance of supervision, group consultation, like continually learning in these modalities, because I know, Rachel, as you know, like OCD can get really overwhelming. And as practitioners, like we could even sometimes get confused by it or sucked into it. We can realize, oh my gosh, we've actually been providing reassurance, or we've been taking these obsessions at face value and digging into them and looking at the person's past. And so I think just giving ourselves permission, like this is difficult to hold on our own. So it's okay to kind of call in the reinforcements and ask for help, get the supervision, and being able to kind of take a step back ourselves and be like, hey, can someone else look at this? Like, can you look at this hierarchy? Can you look at this Y-BOCS and let me know maybe how I can do things a little more effectively? So just wanted to throw that out there for anyone listening who is interested in diving into this more and is like, I feel so overwhelmed by it. Should I get more support?
Yeah. Yeah. And 100%. I mean, I even will catch myself sometimes being like, wait a second. Okay. Google like OCD. Break down OCD again for me? Because I'm like, clients, they do have like a really sneaky way of just sometimes pulling you into like their reassurance or their intrusive thought where you're like, wait a second. Oh my gosh. Yeah. Like, what if you are allergic to something that you've never been allergic to, but I don't want to cause harm to you? It can get kind of like that. So yeah, even me, sometimes I will like just watch like a quick YouTube video, like once a quarter on like OCD to be like, okay, we're okay. Like this is what OCD is. So yeah, it is like messy and confusing sometimes.
Yeah. Yeah. And especially because I think like identifying as somebody who's a helper, who wants the client to get better, feel better, that this sometimes can feel so counterintuitive to that because it kind of gets worse before it gets better. And so that's hard to hold that space of like, I'm going to challenge your OCD and we're going to kind of tackle this head on. It's going to cause a lot of distress. Like that's like painful. And so that can even cause, like, I know for myself, like that can cause me to kind of back up a little, back out a little of like, oh gosh, I don't want to be hurting this person. But it's like, no, I have to constantly remind myself, it's like, it's me and the client, and then it's their OCD. Like I am working with the client against their OCD. Yeah. But sometimes it's hard to separate the two.
Yeah. Yeah. And I always say too, like, I do it with humor a lot. So, cause again, like the seeking reassurance one, that's a big one for clients. And you feel like, oh my gosh, like either I just want to give them that reassurance, let them know, but then it's going to harm them. And so sometimes even just approaching it of like, okay, I'm responding to your OCD right now. Your OCD is looking for reassurance. We're not going to give that to her. We're not going to give that to him. Like, and I'm doing this because I care. So like, again, kind of reinforcing the, like, I'm not going to give you reassurance. I'm not going to give you reassurance. And sometimes we can be like funny with it. And it just depends on the client, you know, if you can be like funny or if you need to be like a little bit gentle and just say, hey, like, it sounds like we're seeking reassurance right now. Do we feel like our OCD is maybe here with us? And usually they're like, yeah, it's here for sure. But yeah, it can feel counterintuitive when they're wanting that reassurance. Normally, for a lot of our clients, I'm sure we like give reassurance, but for an OCD client, it's like,